Welcome to the virtual grand rounds of 2019. My name is Shannon Strader. I am a third-year medical student at Lincoln Memorial University in Tennessee, and I am this year's AADMD virtual grand rounds facilitator. For those that are new, virtual grand rounds are a webinar-based presentation model that creates a space for mentorship, exchange of knowledge and experience between seasoned IDD providers, entry-level clinicians, and future healthcare providers in training. The purpose of the Grand Round sessions is to expand and strengthen the IDD healthcare workforce across the spectrum of experience levels. After this meeting, we will be sending out a SurveyMonkey for feedback on how to improve these meetings. Also, for the attendees, you guys are on mute, but if you want or have a question at the end, you can type on your sidebar, you can type a question that we can go over at the end. I would like to give a little description of who is lecturing us today. It's the Intellectual and Developmental Disability Mental Research Partnership. It was created to learn about the experiences and needs of young adults with IDD while accessing and using mental health services. Their national partnership consists of 6 young adults, 5 professionals, researchers at Boston University, and representatives from self-advocates becoming empowered and the ARC of the United States. They have designed and conducted a web survey with young adults with IDD ages 18 to 30 living in the United States. They have also completed 4 national storytelling sessions that included young adults with IDD and parents. They have identified 8 priority topic areas for young adults with IDD that will be reviewed in this webinar. These priorities highlight the importance of community-based options, choices, autonomy, and control for young adults with IDD. They will also share recommendations to advance research, policy, and practice in areas important to young adults with IDD. Thank you so much for lecturing us and presenting tonight. We're all looking forward to listening to you guys.
Thank you. We're so excited to be here. This is Jessica Kramer, and I'd like to introduce our team today. These are just a few members of our advisory board team. I'm Jessica Kramer. I'm an occupational therapist by training, working with transition age youth with developmental disabilities, and I am the facilitator of the project. I'm at Boston University, and now we'll go through and have each of our presenters give a brief introduction so that you know who you're talking to today. Corey, did you want to go first?
Sure. This is Corey Robinson Rosenberg. I'm a professor of pediatrics and psychiatry at the University of Colorado School of Medicine and longtime researcher, teacher with respect to individuals with intellectual disabilities, and pleased to be here.
Juliana.
Hi, this is Juliana Huereña. I am from Self Advocates Becoming Empowered. I do administrative work and are on several projects that we work with different organizations and self-advocates around the country.
Destiny.
Hi, I'm Destiny Watkins. I'm a doTERRA wellness advocate, and I've worked with lots of different organizations, and yeah.
And Micah.
Hi, everyone. My name is Micah Peace, and I'm from Louisville, Kentucky, where I work at the Center for Accessible Living as a community advocate and engagement coordinator. I help people of all backgrounds and professions, including other healthcare professionals, get familiar with ways that they can make their services more accessible and empowering to people with disabilities.
We'd like to acknowledge the funder of this project, Corey, Tier A, and it was administered on behalf of the Trailhead Institute. And now Corey is going to start out by explaining why transition to adulthood is such an important time period.
Okay, so as you see on the screen, with this project, we took a life course perspective and recognized that transition from adolescence to adulthood can have lasting impacts throughout adulthood, depending upon how the tasks of transition are accomplished. So within young adulthood, there's these three kind of major aspects of transition. There's the transition to employment and meaningful work, which impacts an individual's identity development. Employment for the long term will have long-standing impacts on the person's economic well-being and health. Within transition, a key task is moving out and gaining autonomy from family, and the fact that there's changing social networks. So it's important to maximize mental health and well-being during this time so that the young adult can engage in these key transition points for life. This time of change can also cause increased stressors that can negatively contribute to mental health if support is not provided. And within young adulthood, we know from this project and the surveys and the listening sessions that have been done that we don't know nearly enough about the experiences and needs of young adults who have intellectual and developmental disabilities and co-occurring mental health needs. So the Intellectual and Developmental Disabilities Mental Health Research Partnership is a partnership among the 5 entities, if you will, that you see on this slide. There were the young adults, there were professionals and researchers on the advisory committee. The organization of self-advocates Becoming Empowered was a key player of the project. The ARC, the national organization, was a key part of it. And the Boston University Youth and Young Adults Empowerment, Leadership and Learning Lab took the major role in organizing the project. And the ARC's mission, for those who aren't familiar with it, is to promote and protect the human rights of people with intellectual and developmental disabilities and actively support their full inclusion and participation in the community. And certainly that would be the goal of SABE, Self-Advocates Becoming Empowered, as well. So what we did in this project was construct a web survey, and there were a number of iterations that survey went through. Ultimately, 76 young adults with intellectual and developmental disabilities and co-occurring mental health needs responded. Their age range was 18 to 30 years, and they were all living in the United States. We also conducted storytelling sessions that were on the phone with several calls and also at the 2018 SABE conference. And in those storytelling sessions, there were 10 young adults who participated and 6 parents of young adults with intellectual and developmental disabilities. I think that brings us to priority areas.
So there are 8 priority areas, and the first one was transition to adulthood. And there's always transition going on throughout a person's life, but we wanted to focus on the adulthood, and it can be hard for everyone. Found out that there's a lack of supports and services in areas like employment, independent living, and adult health care, They can contribute to a decline in mental health for young adults with IDD as they transition out of school and into adulthood. On the next slide, we have a quote, and the quote says, "It's difficult to find independent living that knowledgeably supports me with IDD and mental illness. I'm living with my parents and would like to move out, but we can't risk a relapse." And that was from a national web survey. The next quote was from a virtual storytelling session, and they said, "Seeing all of their peers and siblings go off to college and having all of these major life changes, and they are not, contributes to a lot of their anxiety and feelings different." And then the next slide talks about professionals' competence. So we found out that there's not enough professionals that have the appropriate skills and knowledge to work with young adults with IDD and mental health. And on the national web survey, we found out that 65.2% of young adults reported it was hard to find a doctor who knows about both their developmental disability and their mental health condition. And this reduces the quality and appropriateness of the mental health treatment for young adults than what they receive. The next quote we received was from the national web survey, and someone said, "Doctors don't understand how autism, anxiety, and depression can coincide." Another quote from the virtual storytelling session, someone said, "I went to one therapist and I talked to them about all of the anger that I had. But instead of supporting me, he attacked me." Another quote from the national web survey, someone said, "It's hard to find doctors because they go too fast, so they're stressful and I don't understand. Or they speak like I'm a baby because they see I'm cognitively disabled." The next priority was from insurance and financial resources. We found out that insurance can limit young adults' choices for mental health treatment, and also the accessibility to appropriate mental health treatment, which can be cost prohibitive. And even with insurance, sometimes it's cost a lot of money out of pocket. Here's a quote from the National Web Survey. "I could not afford to get mental health treatment until I moved to a state where I could get Medicaid." So it varies from state to state how people receive treatment for mental health. Another quote was, "I would have loved to have my son at home, but there was no way to have him cared for at home. So my only choice was for him to live in residential care. No family could pay over 6 figures a year for care. It takes money to take care of people with mental health and special needs, but their life matters too." Another priority is understanding the experience of people who communicate differently. It can be hard to figure out if mental health treatment is effective when people with intellectual and developmental disabilities have communication differences. Some adults need more time or support to communicate, and some use alternative and augmented communication, and others do not communicate using verbal or symbolic communications. So how can we connect with one another when receiving treatment? Here's 2 quotes. The first one was from the National Web Survey. "Having a hard time explaining symptoms," is what someone said. And the second quote was from the virtual storytelling session, and they said, "We have to judge how medication is affecting our son based on his behavior, his facial expression, his body language. It's been a long and hard process." So we could see how many families are having some struggles with communicating with their medical staff.
Hospitalization. Lack of properly trained staff can make inpatient hospitalization a traumatic experience for young adults with IDD. 26.1% were forced to go to the hospital for their mental health when they did not want to go. I was in the hospital for over 1 month because doctors did not know what medicine would work best from Sabe's storytelling session. I would consistently discuss how I wanted to die without being direct about it out of fear I would be hospitalized from a virtual storytelling session. I lived in an institutional orphanage for the first few years of my life, and so there's trauma around that. So I do not like any type of institutional setting from a virtual storytelling session. Medications. Young adults want choice and control over the use of medication. Almost 30% didn't get to choose their medications. Almost 30% were given a medication they did not want to take. They want their choice to be respected and supported. Medications at first was a disaster, but once my dosage was adjusted and I grew a tolerant to it, it worked wonders for me from a virtual storytelling session. I need better medicine with fewer side effects from a national web survey. We did try medications. It actually had an adverse effect because of how he was not able to metabolize the medication from a virtual storytelling session. Alternative to medications, young adults with IDD-MH use strategies, supports, and options other than medicine to help their mental health. Many young adults reported that therapy and involvement in the community activities help their mental health. 40% said that they are not able to do activities they enjoy in the community as much as they want. Alternatives to medications reported non-pharmaceutical strategies, relaxation strategies such as deep breathing and meditation, therapy, which quote therapists or counselors, doing activities they enjoy to make them feel good, exercise, and doing art or other creative activities. Spending time with their pets, spending time alone, cognitive behavioral therapy, listen to music or watch TV/movies, medical marijuana, and involvement in self-advocacy to learn to stand up for themselves. I tried to do some things creative like writing or doodling to get my mind off things from a national web survey. I got started in the self-advocacy movement and I stand up for myself and what I want for my treatment from Sabe storytelling session. She needs less medications and more hands-on kind of therapy other than taking more pills from virtual storytelling session. My son has the right to go to church but couldn't go. Pretty sure no one's mental health is better when you lock them up and take everything that gives them life from a virtual storytelling session.
Okay, and the next priority area was social supports. So young adults with IDD-MH need support from people they can trust and who understand their experiences. Family and friends can provide strong supports for young adults' mental health. Only 26.5% of young adults have mental health support group they can belong to. This was in responding to the survey. This may contribute to young adults feeling that they do not have support from people who understand their mental health challenges. But young adults often don't get the social support they want and need for their mental health. Only 26 belong to a mental health support group. From a storytelling session, one individual said, I like talking with and spending time with my family and my friends a lot because it helps me a lot. Friends are always the best medicine. And from someone else on the web survey, I am always depressed and people are tired of hearing about it. It's been so helpful for us to have these other families that understand our daily frustration and can share information and also be part of our mental health team. And that was from a virtual storytelling session.
Recommendations. Steps and action mental health professionals can take. Improve medication management by not assuming medication is the first or best option for treatment. Respecting young adults who choose to not take medications or when they choose to use natural homeopathic remedies. That's an error in the slide. But I just wanted to point that out. So, improving medication management by collaborating with young adults and families to identify the medications that produce the greatest benefit and have the fewest side effects. Explaining the risks and benefits of medications, including side effects, in a way young adults can understand.
Another recommendation to improve communication by asking young adults with IDD and mental health how they best understand information. For example, having something written, having someone speak to them, pictures, and follow the request during appointments. Another one is checking for understanding and consent, making sure they know what they're signing. The next one is communicating directly with young adults with IDD and mental health rather than their parents and staff, and that happens more than likely. Another one is allowing more time for appointments when working with young adults with IDD. A lot of times appointments are so short and not allowed enough time to speak with the provider. Next one is learning how behavior is a form of communication. They may be trying to tell the provider something and it's not being conveyed. And the next one is listening carefully to family members and support personnel who know young adults best. They're the best people to be at that appointment to make sure that all their questions and needs are met.
We also have some recommendations for steps and actions that healthcare systems can take and that you individually as healthcare providers and future healthcare providers can advocate for. Firstly, systems can improve reimbursement processes by identifying innovative ways to deliver mental health counseling and supports at lower costs, such as mHealth or telehealth, to young adults with IDD-MH. This would be beneficial for reasons not limited to transportation access and executive functions, sometimes managing many scheduled appointments is difficult for people like myself who are on the spectrum or have other disabilities. Insurance companies should also provide reimbursement for non-pharmaceutical services and support at a rate that is equal to reimbursement for pharmaceutical and inpatient services, because offering more coverage for one service than another is equal to pretty much preferring or prioritizing one kind of treatment over another, and it ultimately limits people's options. So for example, counseling, other outpatient health and wellness services, and community-based treatments, as well as transportation to those treatments, should be eligible for insurance reimbursement. The delivery of care can be improved by hospitals and other clinics adopting a trauma-informed approach to care for all individuals, including young adults with IDD-MH. Service systems, hospitals, and independent providers should have high and low-tech communication devices available for use by young adults with different disabilities and mental health care conditions. These can range from iPads or talkers if you're in a fortunate place with a lot of resources, or even just sheets of paper with images on that one can point to respond. And all materials about mental health conditions and treatment options should be published in plain language and easy to read formats so that young adults with intellectual and developmental disabilities can understand them. And I would argue that this will help others as well. And these are steps and actions that states and policymakers can take. And once again, you as healthcare professionals are in a unique position to advocate for these changes to be made. States and systems can provide more community-based treatment options. And some examples are crisis and prevention planning for young adults with intellectual and developmental disabilities, their families, and direct care providers. Ideally before a crisis happens, and ideally when a person is younger so that this becomes a skill that they can build. And also the adaptation of day treatment or partial hospitalization programs currently available to people with mental health conditions so that they are more appropriate for young adults with intellectual and developmental disabilities. States can provide more comprehensive wraparound supports for young adults with IDD who are transitioning to adulthood. And these wraparound services could include Medicaid waiver programs that include mental health services and support. Improving access to and programming for post-secondary education so that there are fewer people at home watching their family members go off to college, and instead they also have the opportunity to seek out a new stage in life and to better themselves and contribute to their communities in some way. That said, improving access to affordable housing in the community must also be a priority because some of the respondents to the surveys indicated that their living situations were indeed a factor in their poor mental health. And as I stated a moment ago, including planning for mental health needs, not just crisis, but up to and including it, should be implemented into students' IDEA transition plan. And importantly, you can include young adults like myself and Destiny with IDD in peer-mediated recovery services. So this means developing peer-to-peer networks of young adults with IDD-MH so that we can communicate with others who have had similar experiences and developed the coping skills to come through them. Harness knowledge and experiences of intellectual disability and mental health advocates and advocacy organizations like the ARC, SABE, or the Autistic Self-Advocacy Network. And best practices in family support parent-to-parent should also address mental health and provide families with mental health resources. In conclusion, choices that respect the autonomy and the values of young adults with intellectual, developmental disabilities and mental health care needs are the ideal. We need more community-based supports like accessible day treatment, support groups that are led by people who have had these lived experiences, and holistic lives that allow us to participate in leisure, independent living, and work so that we can be a part of our community. And we need healthcare providers who not only understand us and our mental health care needs, but who are willing to work with us in our treatment rather than for us, as so many try to do.
Thank you so much for learning about our 8 priority topic areas and recommendation. If you have any questions for us, I believe now that there's a way to chat or ask questions on the phone, or you're welcome to email me and I can pass questions along to various team members as well.
Hi, thank you guys so much. I don't think there's a question right now, but we'll leave it open a little bit. But I actually have a personal question. As a medical student, learning about the protocols and HIPAA and all those things about administration at this point, I 100% agree from what I've seen personally, which I'm naive to everything now, but being on clinicals and seeing IDD and mental health and all this, there definitely needs to be a longer time for physicians to see these individuals. I completely agree, but how do you guys have a method on, because I know from my standpoint, we learn as medical students, like you only have a set time, and from administration, you could get in trouble, especially as a primary care physician, if you go over that time, and you could get almost fired, I guess. Like you learned as a medical student to be scared and to really listen to administration on, you only have a set 15 minutes. Do you guys have like a way to go around that to physicians? Because it would be nice to have longer, but it would also be nice for administration to be like, hey, like you need longer time too.
This is Juliana. I think I've seen it where sometimes doctors may be able to put something down to say this is an extensive appointment or something like that. I wonder if that's something that they talk about in your classes.
Yeah, I really want to be a physician to these individuals, but I'm also learning, especially with mentors and preceptors, that like a lot of the mentors I have or preceptors, they give, that's all they have is IDD patients, which is awesome. But then administration's like, hey, like you can't have extensive for every single one of them every single day, which is very tough. So I was just wondering, like, if you guys, it would be awesome to do that.
This is Micah, if I may. In honesty, this may not be particularly helpful to the answer that you're looking for, but it sounds like an issue of some misunderstanding of how some of the communication might work on the part of administration, and to me, it's sounding like this is an issue that needs more advocacy from passionate professionals like yourself who very much want to work with our population and very much care and have the basis of knowledge to say 15 minutes isn't practical in a lot of these situations.
Yeah.
And with your kind of expertise, that advocacy will have more weight than coming from someone like me who comes from the patient side of it.
Yeah. Yeah, it's interesting to see, because I think more than ever, I think as a medical student, there's more regulations than there ever has been. I mean, from my personal perspective, because my preceptors, I believe, have also said, there's been a lot of changes in that kind of arena with more of a business model rather than, I guess, the healthcare. But I don't know. It should be interesting. I have yet to learn. I have a lot more to learn. Okay, we have one question.
This is Jessica. I was going to bring up, you talked about the private model, and I was going to bring up issues around managed care. and thinking about opportunities that present themselves through things like managed care, where an entity is reimbursed for a certain amount of money to provide all services. And I think what that encourages is comprehensive supports from a variety of disciplines that inherently have to be more integrated, right? Because in the onus, when we talk about administration and what there is driving them, in managed care, they are actually trying to provide the most optimal services that might cost money up front, but will be more successful and more coordinated, and thus potentially reduce long-term costs. I don't know necessarily if, I would argue that perhaps with more coordinated care, so maybe the physician does still get 15 minutes and that's it. But in a coordinated managed care model, there's an opportunity to also have appointments with a social worker, or appointments with then a therapist or a counselor who then is also talking to the physician, or appointments, sort of with nutrition to talk about potential nutrition and health discomfort that may be contributing to, say, for example, pain or discomfort that could be contributing to sort of negative mental health or challenges in getting out in the community to do things that would contribute to mental health. And so while that physician might still be limited to 15 minutes, if that care is coordinated, then perhaps that's a way to meet that need. I also know that there are some people running clinics. Dr. Brian Statko at MGH, Massachusetts General Hospital, runs a clinic, I believe, once a month that is focused uniquely to individuals across the life course with Down syndrome. And as part of that, they see a physician, but they see a range of interprofessional specialists who coordinate together before and after. And then part of that, from what my understanding is there are surveys that specifically ask about mental health. And not only is there a social worker available there to provide support, but they also have a person who is an advocate, a person who identifies as having Down syndrome, who also is available to talk to clients who come in with their families about issues that might be important to them that they may not feel as comfortable approaching with some of the professionals. So those are some models that I think I can think of or I've seen that sort of recognize limitations on physicians' time, but then optimize opportunities for communication in other ways.
Yeah, thank you. Yeah, that makes more sense. That's clear. Here's one of the questions. Could you explain trauma-informed care? I apologize if it was explained earlier. I was a few minutes late logging on.
Does anybody else want to take it? How about, it's a great question. I'm really glad you asked about trauma-informed care. I will give sort of a textbook definition, and I'll see if other people want to weigh in on sort of what that might look. The trauma-informed care is particularly an approach taken in the mental health field. And the assumption is that any individual who you are interacting with, the assumption is that they have experienced past trauma. And that the assumption is that certain experiences, especially if people are in crisis, might re-trigger that trauma, or if people are responding in a way during crisis that seems challenging. So they're harming themselves, they're doing behaviors that might be harmful to other people. The assumption is to think they are doing it as a protective factor that is related to this past trauma. So that approach is only recently being adopted in the IDD field to thinking about when people are in these crisis health situations and in environments like hospitals, when we see people acting in certain ways or reacting rather than attributing that reaction to their disability, maybe it oftentimes might it be attributed to trauma-informed care. And I don't know if other members of the panel want to talk about then what we really heard over and over again from young adults about traumatic experiences.
Yeah, if I may weigh in really quickly, this is Micah again. As Jessica said, trauma-informed care begins with the premise that anyone and everybody could have experienced a trauma in their life, and we don't know what that could be. It may be impossible to find out, so you have to approach with a more understanding, gentle, collaborative kind of way about you, because the basis of trauma-informed care is prioritizing a sense of safety for the person that you're working with and helping them to rebuild a sense of autonomy and sense of control in their life and in their environment. So even if you have an end goal in mind, the person needs to feel comfortable and needs to feel that they're respected and not that this is an authoritarian situation, because often growing up with IDD, and this is something that we heard a lot in our surveys and our storytelling sessions, that we are often sent the message that we do not matter at all, and that we cannot possibly know ourselves, or that our internal experiences aren't valid, because again, as Jessica pointed out, they're very often just attributed to our autism or to our other disabilities. And that has a very damaging effect on a person, especially if you have it happen to you again and again and again. So when it comes to trauma-informed care for people with intellectual and developmental disabilities, a lot of it will have to do with letting the person know that they matter, and that their views on their experiences matter and have weight to them, and helping them learn a sense of self-awareness. And even like for me personally, because I can really only speak for myself, it has taken quite a lot for me to, I had problems with doctors growing up because I was very, after having experienced some medical trauma, I was very, very obedient. I was ready to do whatever the doctor asked of me, take any medication, do whatever. So my answer to any question was yes. So people didn't get very far with me because I was too scared to communicate what was really going on with me. Does that make sense? Because that is really why trauma-informed care is so important, because even people with intellectual and developmental disabilities can intuit whether or not it is safe to disclose certain things, or whether or not something is okay for them to express. They might not be able to tell you that they can tell with their words, but if someone is having a meltdown in your office, if someone is running out of your office, it is probably more down to fear and to past experiences and association than to that particular intellectual or developmental disability.
I think you made an excellent point about having kind of this label, and whatever healthcare you get or whatever complication or symptom you're feeling, that's almost as if they physicians or healthcare providers sometimes think, okay, well that's what you said, your autism, or, and so I think that's a really good perspective to keep continuing to educate people on.
Thank you.
All right, next question. Are there any programs or tools to educate healthcare providers in IDD to facilitate more positive interactions and communication?
There's a toolkit, and I will drop the link in the chat. It is IDDtoolkit.org, and it's produced by Vanderbilt.
Thanks for sharing that link, Micah. There is also, I'm frantically looking through my cards because I was at a conference yesterday. I also found out that the University of New Hampshire Institute on Disability has something that they call a responsive practice training. Micah, I can't, because I'm the presenter, I can't actually get my cursor to access and open the chat. Did you mind?
Sorry, wrong host.
Oh. Is it showing up in the chat box? I know that Micah was trying to add that in there.
Yeah, it's in there.
Great. And again, the other one, I'm sorry, I can't type in it. University of New Hampshire Institute on Disability Responsive Practice Training.
All right, we got several thank yous, and the next question is, are there any tools, questionnaires available for an individual's team to utilize in order to help guide caretakers answers to a healthcare provider's questions to be more efficient in gaining information? This is geared towards an individual who is not verbal and has difficulty verbalizing their needs.
I'm going to weigh in because I'm a measurement nerd and a questionnaire and assessment nerd. To be perfectly honest, there have not been good sort of survey or assessment tools or health outcome, patient-reported outcome tools made to be accessible for individuals with IDD to report on mental health specifically. There are some tools and questionnaires that are a little bit more broad, in which young adults with IDD, they've been used to just have them report on sort of general satisfaction with life. There is a modified quality of life scale that if you just Google quality of life, intellectual developmental disability, and Google Scholar, I'm almost positive it'll pop up. I believe it's from some authors in Europe. So that could be used in a broad way to understand how people are perceiving their quality of life and well-being, and one facet is that their mental health could be impacting that, along with other things like social integration or isolation. I wonder if other members of the team have some creative ideas that may not be sort of standardized tools, but ways of getting input, feedback, eliciting concerns from clients with IDD.
This is Juliana. I think one of the most important things is when someone who has intellectual and developmental disabilities, if their support persons can help prepare them and write down questions that they want to know more about the issue that they're going in to see the doctor or provider about. So just pre-planning before the appointment to make sure that their needs are met, and just be prepared with those questions already ready to ask.
Okay, next question. Is there a model in place that facilitates communication between mental health providers and teachers for developing IEP plans that address mental health concerns?
This is Jessica. I'm not aware of any models. which is sort of why we put that in for recommendation. I don't know if people can speak to any maybe examples that they've heard of individual teachers or IEP teams or students really advocating for that. I do know that there have been a few across the country, sort of some specialized teacher training programs that have tried to integrate general healthcare transition skills for healthcare management into IEPs. For example, I believe there's one at the University of Florida. It's not specific to mental health, but it's a sort of a training and a way to help teachers understand how important healthcare management is as a transition skill.
This is Micah. This may be a bit tangential, but I have heard recently of something called the zones of regulation that's being used in classrooms by teachers to kind of help students with IDD become better at self-regulation and identifying certain emotional states. So this is kind of a precursor, I guess, to what the question was asking about, kinds of having more in-depth and planning-oriented conversations about mental health. But I think that since Jessica pointed out, there isn't a lot of that currently really set in stone. That a lot of it will begin kind of with learning to help students identify their own emotional states, because that's where we begin to notice mental health difficulties, right? So again, that's the zones of regulation, and it gives students with IDD, even young students, both the language, whether it's verbal or not, and a visual representation of emotional states and feelings, and things that one can do to cope, by putting them into colors. So, for example, sad or tired would be blue, upset is red, green is like, okay, ready to learn, and yellow is you're kind of anxious, escalating sort of thing. And I don't know if that's helpful at all, but I thought of it, so I wanted to share.
Next question. This is the last question. Are you familiar with a Clubhouse as a community mental health service model and how it works with people with IDD and MI? What adult day program models should be the future of support of young adults living with IDD and MI?
The Clubhouse model is awesome, and it would be, I think, the ideal community-based, peer-led, empowerment-focused model that we're sort of proposing, or that young adults are asking for or looking for. I am not aware of any clubhouses that are explicitly including or excluding. They're open to anyone. Oftentimes, the service system for people who identify as having a developmental disability is siloed and separate from the service system for people who identify as having a mental health condition. And so oftentimes people are not aware of these other services or are restricted from receiving services from the other institution if they sort of are receiving services in one. And so that was, I don't know if members on the board can share any experiences or examples they know of people in various states or various organizations sort of trying to break down those silos or trying to integrate those service systems. So unfortunately, no.
Sorry. There's actually a couple more questions. Is that okay if we continue, or do you guys want to say email if they have any more questions?
I'm available for a few more moments.
Okay. We'll just take this last one. I'm a psych advanced practice nurse focusing on care and ASD and IDD population. Are there any successful programs that are more team approaches in healthcare treatment?
I'm sorry, could you repeat the last part of the question?
Are there any successful programs that are more team approaches in healthcare treatment?
I'll have to defer to Jessica on that one.
This is really interesting because we were at a conference yesterday and I heard some examples. They were, one example was inpatient based, which hospital based, which again is not, and full hospital, again, not ideal, but recognize that sometimes the best option for safety. The state of New York, I believe, is working in a collaboration between, and I apologize, I don't remember the name of the hospital. A hospital is working with the state DD system and a variety of professionals from the hospital, as well as people with disabilities and their family members, and they are opening up a small unit that is all focused on patients with IDD and mental health needs. I believe that was, again, sort of like, groups that would be accessible, a range of professionals. So that sounds very interprofessional. I don't remember what the hospital was, but I wonder if you Google, if you'd be able to find it. I also heard about a program in, now I don't remember if it was North Carolina or South Carolina, that was a partial or like a day program that was specifically for adults who identify as neurodiverse or who identify as autism. And I didn't hear much about the program, but it was specific to adults, I believe, with autism who also have mental health support needs. So I think these programs are growing and they're out there. And one of the challenges that we've had is it's been very difficult for everyone to find each other. And so I think a lot of people are reinventing the wheel. And I wonder, I think it's an exciting opportunity perhaps for your organization because you are national and your sort of membership based. Is there a way to create a special interest group or a subsection to bring people together around this topic so people can learn from each other and advance this field perhaps a little bit more quickly?
All right. Well, I really appreciate you guys giving this presentation. It is very nice to hear from self-advocates, especially. And thank you again. And I'll be sending out an email with your contact information if somebody else has a question.
Thanks, everyone.
Great. Thank you for having us.
Thank you. Have a good night.
Night.